Be presenting. My name is Sherry Stoka, and I'm doing the program with Erica, who you've may heard talk in some of our monthly sessions. But I'm super duper excited to dig into this topic. Like we say all the time, we're really fortunate to be able to work with patients on a more intimate level, just because of the nature of the business model and obviously owning the business and really kind of dictating what all goes down from really a treatment perspective. So today the agenda is going to look like this. I am going to review some things because just general, kind of root cause, kind of foundational stuff, because I do think it's really, really important. Some of it is going to absolutely be a review, but again, it's really important as we kind of get into the GLPs. But I'm going to talk about the root cause of metabolic dysfunction and weight loss resistance. You're going to have a better understanding of the GLP-1 receptor agonists, what they are, what they're doing in the body. I am going to discuss the mechanism of action and their metabolic effects. Just making sure I'm recording this. I'm going to talk about different fat stores in the body and how they become resistant to weight loss. We'll talk a little bit more about the visceral fat and who's going to be a good candidate for the GLPs and who's not going to be a candidate for the GLPs. I forgot to mention what I would prefer to do. I'm going to run through the slides. I'm going to try to run through them very quickly, and then we will open it up at the end for questions, because I'm not going to be able to look in the chat and be able to manage it kind of how we do in our other platforms. So if you want to just write down your questions, and then at the end, we'll absolutely open it up and have a discussion. So my presentation will hopefully be like around 30 minutes. Okay, so we had sent you all a enrollment link to Thinkific. So all of the recordings, all of the resources that we share for each of our sessions will be housed there. So if you haven't set up your account yet, make sure that you go ahead and do that. And if you need help, we will certainly troubleshoot any of that with you. And you will have access to the training for 1 full year. All right, I'm going to start out with this slide. It seems probably a little odd to, kind of throw this out there, but I just want you to take like 5 to 10 seconds to think about this slide, and just kind of the first thing that comes to your mind, and just write it down, because I'm going to ask you a question at the end and see if kind of like something's changed. And then the next slide, again, just take a few minutes to look at the slide and what comes first to your mind. Okay, so we all know that obesity is multifactorial. I don't need to convince any of you of that. So the standard American diet, there's multiple things that come into play. Lifestyle habits. We absolutely live in a toxic world. We are fed toxic food, and that is causing a whole host of issues. But gut issues, so gut dysbiosis, hormone imbalances, mental health issues, and we are now at a point where we are very overfed and very undernourished. So our approach is always treating the foundation, because yes, we can go and look at other things, of course, but at the end of the day, our goal is to really get to the core so that we can get the body to do what it was designed to do, what we were put here on earth, and living in this amazing body, and we want it to get back to its natural state. So metabolism, again, just to kind of ground us all, we all know what metabolism is. And most people, when they hear the word, they think of, oh, is my metabolism slow, or is it fast? And is it helping me, lose weight, or am I gaining weight because my metabolism is slow? But at the end of the day, metabolism is crucial for almost every function in the body, and we need food in order for us to create that energy and supply all of the basic needs. So, we need to use food for breathing, blood circulation, digesting food, growing and repairing cells, managing hormone levels, temperature regulation, etc. So it is so important that our body is utilizing the food, obviously that food that comes in. And I've been kind of saying this for quite some time. And, when you really stop and think about all of the issues that people are having with their weight, it's really not surprising, because why would we think people can lose weight when there are when there's so much metabolic dysfunction in the body? And the majority of people have some sort of metabolic dysfunction. They've done several studies now showing that 97% of Americans have some level of metabolic dysfunction. Obviously, that varies, depending on the person significantly, but most people walking around now have metabolic dysfunction. So the obesity narrative is all wrong. And I continue to see it, I continue to read it, and it kind of makes me a little crazy. But obesity is not the cause of all of these metabolic issues. High blood pressure, high cholesterol, autoimmunity, heart disease. Obesity is a result of long-term metabolic issues. Over time, the body slowly begins to adapt to these altered metabolic processes, making it impossible to lose weight by lowering calories and exercising more. And again, this probably seems really obvious, but I don't think even, when you're in practice and you're working with people, we're so conditioned to react to what is in front of us at the moment, when really, what has been transpired in the health of most people started 10, 15 years ago. So it's really, really super important to understand that metabolic health is going to dictate whether or not a person can lose weight and continue to maintain it long term. So our bodies are out of balance. We were taught in school that 3,500 calories equals a pound of fat, so if you look at, this is just again, a simplified version, but if you think about it, this particular person has 101, I was trying to go as long as I could without my glasses, but 101 pounds of fat. So we do, we're obviously looking at like body composition. And if there's 3,500 to 4,100 calories in a pound of fat, well, that would mean that this person has over 400,000 calories stored in their body for use. And so when you think about it, why wouldn't the body start to use those calories effectively when we use the strategy of creating a calorie deficit? Why does it not work, or why does it work for about 2 weeks and then it absolutely stops? And again, it is all because of the dysfunction and how the body now is accessing energy when it is in need of energy. So I'll talk a little bit about the fat cells. All fat is not the same. This is important to understand, but this is just a very simple diagram of different fat cells. So white fat adipocytes are very different than brown fat. And again, you'll have to excuse me because I don't know what level you're coming in as, and you may know all of this, but it's just important to point out some of the important aspects of the fats. So white fat cell, very basic. You see it has a nucleus, it has mitochondria, not very much mitochondria, and then it has a larger fat droplets. And then you have your brown fat cell that is full of mitochondria. It has a smaller fat droplets, has its cell nucleus. So they have very different functions in the body. So I know this is hard to read, and I will have to put my glasses on for this one, but so we have your white fat cell, your brown, and we also have what's referred to as a beige fat cell. So the white is, you can kind of see, breakdown of this, and we have a handout for you, but it is basically it is it's the fat storing fat cell. So it has very little mitochondria, because the most important part about being able to burn fat is moving the fat cells into the mitochondria. So the white fat cells are not effective at doing that. They literally store calories, and then you can see, other functions that they do. So it secretes leptin, adiponectin. It's very, very inflammatory, versus the brown fat, which is metabolically active. It actually helps the body utilize and burn more fat, and it helps with glucose uptake. So it has a very, very different role in the body. And then you have your beige fat, which is kind of considered like the neutral fat cells. So if you're doing the right things, such as high intensity exercise, intermittent fasting, cold plunging, you can turn the beige into the brown. You can convert it into the brown fat, so you do have more metabolically active fat cells. So it kind of remains neutral, and then relies on kind of habits and things like that. So I'll get into obviously a little more detail on this. So when you look at just the simplistic way that the body stores fat, you have your subcutaneous, which is the pinchable, and then you have your visceral, which is the deeper belly. And obviously the visceral fat is what causes all destruction in the body, and what is absolutely resistant to like the calorie approach and exercise approach. So if you kind of think about a freezer and a refrigerator, it's the same kind of concept with subcutaneous fat, which is the pinchable, or the visceral fat would be considered like stored or trapped. And it's kind of the same concept with the freezer. It's there. You have access to it, but you can't use it. So we have to move it into an area, meaning the mitochondria, where the body can actually convert it to ATP, and it can be used for energy. So I saw this analogy a while ago, and I just thought it really made a lot of sense, because of the fact that, people just they have a hard time understanding why the body will not go toward to the visceral fat when the body needs calories. And I am going to talk about that more. But where this all begins, so it all starts, all of the dysfunction starts with glucose variability or blood sugar dysregulation, which again, you all understand. But this constant rise and fall is creating, so much destruction in the body, inflammation, and then inflammation starts this cascade of things. So when I think about what is the root, what's the root cause of all this? I mean, the root cause obviously is food. The standard American diet is what's causing all of, the dysregulation and dysfunction. But when you look at it from like a physiological standpoint, it's insulin sensitivity, blood sugar management and things like that. So what happens, obviously, pancreas is overworked because, the body's not responding to the insulin. So more insulin is being pushed out. And eventually you get to a point where you absolutely cannot clear the sugar from the blood. And when the sugar stays in the blood for too long, it basically sends out all of these warnings to the body, because it's so dangerous, right? I mean, we know this. So what will happen is the body has a mechanism of, called lipogenesis, that will convert the sugar into triglycerides, and it will shuttle it into the visceral. So once that whole process happens and the sugar gets basically turned into fat and gets pushed into the visceral, that becomes its own kind of organ on its own. So now our visceral fat is problematic, right? So it's secreting hormones and chemicals that literally affect the whole body, you know, full systemic inflammation. It secretes leptin, it secretes adiponectin, which affects blood sugars, produces cytokines that causes systemic inflammation, and produces angiotensin, which causes the blood vessels to restrict, and now the blood pressure, now you have elevated blood pressure. So it starts, so I just wanted to kind of review where it starts and why the visceral is now playing such a huge role in the continued destruction of the body. So then we get back to, all right, we have this visceral fat. How do we get rid of it? Well, the problem is that the reason why because the body's so smart, and that's what I used to ask myself. I'm like, the body's so smart, like, why are we not able to access this visceral fat? And it's really because of its inflammatory nature, and it literally becomes the dumping ground for all of the processed foods that we're consuming and we can't get rid of because now our liver is fatty and it's congested, and now these fat cells cannot move into the mitochondria. It is incapable of doing that. So the patient will never, ever really get out of that imbalanced state, because it keeps kind of compounding because of the metabolic dysfunction that is not being addressed. So this is why calories, just telling someone to lower their calories doesn't work, because it's, your body's going to go a little bit to the subcutaneous fat, but it literally will not touch visceral unless, you're working at it for long periods of time. So then what happens is now the immune system gets involved, right? Because now you have your visceral fat is constantly producing inflammatory compounds. And this inflammatory response now triggers to the immune system, because it's just the natural way that the body responds to inflammation. Inflammation in the body is normal, but now we have this constant, inflammatory state, and now we have the immune system that's constantly being triggered, and now the immune system is confused. So lo and behold, now we have an autoimmune problem, and that's just creating more and more destruction. And really, it all started because of, the food that is available to us, which is very, very sad. All right. So now we're going to get into the GLPs. Okay, so GLP-1, glucagon-like peptide, these are incretin hormones. So you have the GLP and you have GIP, which I didn't want to talk too much about GIP yet, because we are going to talk about that in another one. But so the GLP is one of the incretin hormones. So these are secreted after you consume food. So it basically, one of the main foods that drives GLPs is fiber. So there are many other nutrients that will signal GLP, and GLP will do what it needs to do with all the other receptors in the body. But it is a natural, a very, very natural process that is supposed to happen every single time you consume food. And I'm gonna talk more about this, but when GLP is signaled and is secreted in a short period of time, it will come down and wait for the next time the person eats, and it will do it all over again. So when you think about the GLP receptor agonists, so now the medications, which are provided obviously exogenously, these are designed to mimic what the body is supposed to be doing. So I'll obviously get more into that, but its main mechanism obviously is to affect gut motility, appetite suppression, and and insulin secretion. So before we get into that, I just wanted to kind of talk a little bit about the GLPs over the last 20 years because they have been around for 20 years. And I think people people are questioning, like, why, if they've been around for so long, what was it about just the recent 4 or 5 years that just completely took off? Because these, people with patients with diabetes have been on these medications. So anyway, you can see in 2005, exonatide, what is that one? I wrote it down because I don't remember the brands, but Byetta, that came out. And the important thing to note here, so 2010, they came out with another one, 2014, 16, and then 2017 is when semaglutide came to be. And obviously now there's even more and more and more coming out. But what's important and why these GLPs have evolved over the last 20 years is really because of the half-life of the medication or peptides. So they're peptides. So you can see here, the first one, it had a 2.4-hour half-life. So when they first came out, patients had to give themselves injections 2 times per day. So that failed miserably pretty quickly. And then, they started to, reinvent, and it evolved until, up where they were then able to give patients the injection, obviously 1 time per day. So you can see here, they went up to the 13-hour half-life. This one was a 5-day. This one was still a 3-hour. But now the semaglutide has a 7-day half-life. So patients do the injection 1 day per week, and that is doable. So what we don't know at this point is, how the tirzepatide, retatrutide, the other medications, how that's all going to kind of come into play, because it doesn't really have the history that we have with, like, the single agonist, which is, the semaglutide, the brand names Wegovy and Ozempic. So when you look at the structure of the peptides, so they are 33 amino acids, I believe, 33 amino acids. This one right here is the native human GLP. So, it's exactly the same as the liraglutide and the semaglutide, with the exception of a fatty acid that was added to the amino acid chain. So again, to reiterate, the half-life of our native GLPs is 1 to 2 minutes. So you eat, you get the rise, it hits all the receptors, does what it needs to do, goes back down to baseline. And then they came out with liraglutide, which was Victoza, that had a 13-hour half-life. So they were making progress. But now you have semaglutide that it is slightly different. You can see there's some variations in the amino acid chain. They say that it's 94%, a 94% like replica of the natural, but it's not exactly the same. So, and it has to be different because now you have a half-life of the 165 hours. So, the 7 days. So this is the big questions that we're asking, because again, I've mentioned this before, but we've always been told that peptides they mimic normal physiology. These are natural, these are signaling molecules. And the more we're digging into the actual, molecular structure of these things and seeing how they're different, we also want to know, we have long-term data on our natural GLPs and some of the, original medications that are out there. But really, what is it going to mean for the human body that has GLPs just elevated at all time. Because again, remember, it's supposed to go to baseline in 1 to 2 minutes, but now it's staying elevated for 7 days, and then you're taking another injection. So it never has a chance to go down. So this is like a part, and I have researched, I can't find really any research that's looking into this other than it states that right now they have not seen any long-term effects from keeping the GLP at a elevated level for long periods of time. So the other component that we want to know is we are injecting this. It's close to the original GLP peptide, but it's not exact. And what we do know is there are some peptides out there that people have reactions to. So is the body recognizing, these peptides as the natural thing, or is everyone different? Are some people, creating antibodies from it? So those are things that we don't know. And then the other part is the receptor saturation, because we definitely know that when you constantly have elevated levels of GLP, your receptors are going to eventually become saturated, right? So it's going to basically plateau, and things are going to stop. So the question is, that's all fine. We have strategies to fix that, but we don't really know what that cell is, how well it's regenerating afterwards. Okay, so mechanisms for weight loss. So this is the 101 version of GLPs. They act on the pancreas to stimulate insulin. That we know for sure. And metabolic dysfunction starts there, so that's helpful. They signal to the brain that controls appetite, so it affects multiple parts of the brain. There's GLP receptors in the brain. And then it slows gastric emptying to, enhance the fullness for people, they feel fuller longer. So slower gastric emptying leads to a slower rate of lipolysis, which actually can be a positive thing, lessening the chance of more fat going into the visceral, because when the fat is exposed to lipases for a longer period of time, it has the opportunity to really break down and use these free fatty acids. So a lot of people are talking about how bad it is for the slow gastric emptying, but it can be a positive thing. And then obviously the slower rate of stomach emptying can regulate the absorption of glucose, so it can obviously modulate like spikes and things along those lines. So with everything that's going on right now in our health, standard American diet, ultra processed, causing leaky gut, dysbiosis, there's so much inflammation. We have reduced enteric neurons are not responding to normal signaling, and we have this excess visceral fat. So now we have what I have come to the conclusion is that now we have GLP resistance. Similar to insulin resistance, we've created humans to now have GLP resistance, because I'm going to talk about all of the positive things that GLPs do for us, but people are not experiencing it anymore because the GLPs are not even responding, because we're not feeding it the right food in order for the response to happen. So another part of all of this is the metabolic health, and I would be really curious to hear if you guys have heard this from other clinicians, doctors, because I've heard multiple times that GLPs do not improve metabolic health. They only decrease one's appetite, so people eat less, and that's why they're losing weight. And that really couldn't be further from the truth. The GLPs absolutely improve metabolic health. I mean, they're affecting the insulin sensitivity. You're getting now this GLP signaling that you've never had before. It's improving the energy balance in the body, and GLPs decrease inflammation. So they have a very comprehensive effect on the body. So it is more than just the weight loss. I was actually going to take this out, but I'm just going to put it in here because it's just making a point of an example of two different interventions that we've been seeing over and over and over. And now it's just like, I usually, almost every single patient that comes up to us, they're like, I can no longer lose weight anymore, no matter what I've tried, it never happens. And my statement is always like, well, I mean, because you have metabolic dysfunction. So some people will choose to still try, natural route and all of that, and that's all fine. But so if you gave, a 50-year-old woman a 1,500 calorie low carb diet, you told her to exercise 3 times per week, put her on a couple supplements, and, you had her go on her way. She comes back with, that person is not going to lose weight. She just is not going to lose weight because of all the dysfunction in the body. But if you give her 1,500 calories, low carb, same exact thing, supplement regimen, but you give her a GLP, she's going to lose probably like 3 to 4 pounds in 1 week. I mean, that's what we see. That's how effective these GLPs can get the body to start doing what it hasn't been doing for so long, because the GLPs are like completely dormant. So again, reiterating, metabolic dysfunction, that's why our body is just in a state of resistance. Okay, so GLPs, glucagon-like peptide 1, these are located everywhere in the body, everywhere, brain, mouth, heart, obviously our gut, our fat tissue, our muscles, obviously our pancreas, our bones, kidneys, liver, they're everywhere. So you will start to see other benefits. And these are just some of the benefits that we see when patients are on this. So they're coming in, they're losing weight, that's all fine and dandy, but then they're like, why is this happening? Now, why is this happening? So some examples would be decrease in pain. I have one particular person that off the chart pain all the time, took one little dose and her life changed. So we do see that. A big thing is food noise, with our GLPs no longer getting the signaling from the food any longer, people are dealing with so much food noise. They cannot stop thinking about food because, again, the proper signaling is not happening. So now you take the GLP and the food noise that we hear all day long, food noise is gone. They have an increase in energy because they're actually using their fat stores for energy. The brain, it's affecting receptors in the brain. So they're not only, controlling their appetite, but now they feel better. They feel more alert. They can focus. And you probably heard about this in kind of in the news, because they are going to start doing more research on this, but what exactly is the reason for people having a less desire for bad things? Alcohol. My mom just told me the other day, well, she stopped drinking alcohol because she doesn't like it anymore since starting GLPs. And then she also just told me that her favorite thing her entire life was potato chips. And she said she can't eat potato chips anymore. So, I mean, you hear these different things because of all of the different effects that, in a positive way, that are happening. So, taste preferences, and then we hear people are sleeping better as well. So who is a candidate for these medications? Again, a lot of people have opinions about this. And of course, people with pre-diabetes, PCOS, fatty liver disease, dementia, autoimmune disease, weight loss resistance. These are all very, very good candidates for this. But then you can take it a step further and say, well, really anyone with metabolic dysfunction would be a good fit for the peptides, for the medication. Because again, it goes back to, if you just kind of look at this diagram, the metabolic dysfunction probably started here, like, again, I've used this one before, so excuse me if you've heard this, but let's just say you're 40 here, right? And you were put on a blood pressure med. So now you have metabolic dysfunction. So over the years, it just gets worse. So how about getting the body into, that healthier state at this point, rather than waiting to now you're in obese and your metabolic health is completely jacked. So, I won't get into like how I feel about it, but it's just something to think about and kind of, be more open to other, you know, other people that may be interested, but they're not necessarily obese. Maybe they're just a little overweight and they're looking to improve their health. Okay, so who is not a candidate for these peptides? So there are contraindications. There's two main contraindications that are absolutely out for people, and that's personal history of a medullary thyroid carcinoma. So it's a specific cancer. I have never ever seen anyone have it. And then the other one is the multiple endocrine neoplasia syndrome. So again, we have never seen it, but it is the two main contraindications. Other people, other populations that would not be good fits, obviously pregnancy. You have to be very, very cautious with inflammatory bowel conditions. Pancreatitis, you have to be very, very cautious of that. Anyone with gallbladder disease or a history of, you've probably heard all this, but gastroparesis, anyone that is going to be having surgery and, within like 2 to 4 weeks. So it'd be either, even pre-surgery and post, just because it can affect the anesthesia because of the slow motility, gastric motility, and that type of thing. And just some precautions would be women who are on birth control, because the medication affects the absorption of birth control. So if a woman is trying to prevent pregnancy while being on birth control and starts GLP, well, there is a chance that she could increase her chances of becoming pregnant because of it. So it's something to just be aware of. And then anyone who has severe constipation, typically people that have underlying gut issues already, they usually don't, obviously they don't do as well. I mean, we have seen people, we're working on their diet and we're dosing, lower and things like that. But if something is more on the severe side, usually you got to work on the other stuff before they can start the GLPs. Okay, so these are just some things to think about as you're working with patients who are on GLPs. And these are, you can just, I just wrote these down because I was kind of putting myself in, a place where maybe I was a dietitian in the hospital again, or in my private practice where I wasn't really hands-on with the medication and had options to kind of do things myself. So, what would you do when you think a patient is not a good candidate for GLPs, but that patient was referred to you by a doctor? So, again, something to think about. What should you do if the patient is not losing weight? What would you do if you believe the patient was on the wrong dose? What would you do if the patient has significant gut issues but still wants to stay on the medication? I think it's really important when you're working with these patients is to know what their weight loss expectations are. And, they should know what your weight loss expectations are too, because, when we're starting people on these medications, we are telling them what the average weight loss is. And when they are on it for a while and they're coming in for follow-ups, and they're happy at, say, 2 pounds per month versus our average, which is like 8 pounds per month, you want to be sure that you're communicating and in alignment, because you could be thinking that they're not doing well because they didn't meet like your expectations, but they're happy as can be because they've finally started losing weight. So we see that often. So we're always trying to make sure that our expectations are aligned. And then just being able to explain the pros and cons of the other, not only the GLP-1s, but there's going to be opportunities where you're going to be working with patients and they're going to say, I've heard a lot of really good things about tirzepatide. Do you think I should try that? So, and we're going to talk about that, but it's just something to kind of think about as you begin to see more patients. All right, so the summary is GLP-1 agonists are peptides that aim to mimic normal physiology. They can improve metabolic dysfunction. They can improve other disease conditions when applied correctly, of course, in concert with other foundational interventions. GLPs can treat obesity and they can prevent obesity. And the benefits far exceed just weight loss. Again, there are many other ancillary benefits. And but again, it always comes down to we still need long-term data, especially with the newer ones coming out, the dual and the triple agonists. So in the Thinkific platform, we're going to add, after each session, we're going to add some of our resources. So this is just an example of two of them that you can find in that platform. And that's it. I'm going to open this up for questions. If you want to unmute yourself, or I can go into the chat. Okay, yes, we are going to be adding the slides. Okay, Karen, if you can't unmute, you can message. I don't know why. Maybe I have to allow that. Let me see. Yeah, okay, I'm not sure. The slides are going to be uploaded today. That's what Erica told me. So she plans on putting that all in right after this. Did I talk too fast? I know. Some people say I talk too slow, but the majority of people say I talk way too fast. So hopefully that was helpful. And okay, we do have some other. How quickly do you see a decrease in inflammation with patients? Fast. Assuming that they're doing all the, when I say all the other things, I mean, the main thing is the diet, the food, getting people off of the standard American diet and having them eat real food is incredible how quickly we see inflammation go down. So to answer your question, I would say, I mean, we see inflammation go down. We typically see people every 2 weeks. So we will see inflammation go down. And how we measure that is obviously symptoms. We can measure, we look at fluid retention, but we can also in our in-body, we can see extracellular water versus intracellular water. So we do have ways of measuring inflammation. Is there a benefit in waiting 3 to 6 months and working the basics before starting a GLP? I mean, that's a great question. I know I've heard a couple people say that when someone is a metabolic wreck, that you can't just put them on GLPs and everything is fine and you need to prepare the body. What I would do if someone comes and they're in their, everything, they're on multiple medications, they're a disaster, they're not eating well. What we typically do is we'll, I mean, if they need testing and gut stuff first, I mean, we will do that. But if we will move forward with doing like a low dose, a very low dose, because of what we're finding in the research now, in that it can immediately support that decrease in inflammation. So we will low dose people. We won't titrate up, like, especially like, with the recommendations that they do with the pens. I mean, we do keep people low and we have really, really good results with that. Do incorporate CGM along with diet and GLP. So we've looked into CGM so many times. And before Karen, when you advised us all that we could get, I think it's the Stella now, we are looking into that because we um, want people to manage their blood sugars, but we're not doing that right now. We're going to be doing a study in January on the new retatrutide, and we're just going to be we're going to be checking everyone's insulin before and after, insulin A1C. And at that point, if we do CGMs, I'm not really sure. We have so much going on right now. So I don't think we're going to do CGMs in the next couple months, unfortunately. Do you ever help people sort of toggle off of GLP to increase motility? I'm wondering if it impairs the MMC. Yeah. Do you ever add in prokinetics overnight? Yeah. I mean, that is a great question because the, so the MMC, the mitral, what is it? The mitral or the motor complex. I can't think of the word, but um, I don't know if yes, migrating motor complex, exactly. It's such a great question because when you think about it, when you eat, that stops the migrating motor complex, right? That completely inhibits the process. So if it's mimicking that, and you're getting that rise in GLP, I would imagine that's shutting that whole system, that process off. We don't know. I don't know if there's even studies that are looking into that. But what we do know, there has been one study looking at the microbiome and the GLPs, and what it has shown is that, because a lot of people who are obese have a lot of abundance of bacteria overgrowth, opportunistic overgrowth, and that type of thing. So it's showing that these GLPs will decrease the abundance of the bacteria. So that obviously is helping with weight loss as well, because the bacteria are not extracting as many calories. So that's the only positive, that's actually the only study that came out on the recent medications. But I don't know, my brain is going on the MMC right now because it's kind of like taking you out of a intermittent fasting state. And so that's interesting. I'm going to definitely look into that. Have you guys been seeing a lot of patients? Are they usually on the pens, or are they on or maybe you don't know, maybe you haven't really had those conversations, but I guess, yeah, I'm curious to see kind of the type of patients or challenges that you're seeing, or successes.
Sherry, this is Abby. Can you hear me?
Yes.
Yeah. So I have a quick question that I can respond to. So with your clinic, like, are you guys able to prescribe GLPs?
Yeah.
Okay. So you could do that as a dietitian?
Yeah, so I have a medical director
Okay.
and then I have an NP. And so we develop all protocols.
Okay.
So we follow like all the, so they'll have their medical assessment by our NP, but all protocols are like cover us for the ability to identify ideal candidates basically and dispense it.
Okay. Got it. I was just curious how that worked because
Yeah.
I think one of the things that I run into is that, I get clients after they've started and are an absolute mess because they've just lost a bunch of weight and still are eating like crap.
Hmm.
But then now don't know what to do kind of thing
Hmm.
because and then, but also I have some that like don't have insurance that covers it. And so then they don't have access to it, or it's finding a practitioner that will prescribe where you pay out of pocket. Um, and I know that those exist, but not on, I don't know what your recommendations are there.
Yeah. So, I mean, I don't know where you're located. If patients don't have, I mean, people can get access to it. I mean, there's a lot of a lot of businesses even beyond weight loss that are offering these. That's kind of part of the wild west of this GLP is that now, say like a Medi Spa that never offered weight loss, but now they're seeing, the opportunity. So now they're just like handing it out. So that's where the mismanagement is being, perpetuated basically. But, your situation with seeing the patient that lost all that weight and now you have to go back and kind of fix things is exactly what I thought was going to happen. Because if you can't talk to that person when they started and make sure they understand the importance of muscle mass, the importance of healthy eating now, because they're now probably just skinny fat. They probably lost all of their muscle and now they will be in an unhealthier state moving forward. So that is happening to people. I mean, we hear it all the time. So as far as are you asked, I mean, I don't know what your question was after that.
Yeah, I guess it was more of just kind of, I think part of that was just kind of explaining the type of clients that I get in now, that I see more regularly is people that have already been starting on them and then come to me because they're miserable,
Yeah, I
because they
think
don't know how to eat.
Yeah, well, I mean, the first thing is that, unfortunately, not everybody's going to have a baseline like body comp. I mean, if there's, I don't know your scenario if you're online or if you're working with someone and they're coming in, but like you have to do body comp testing. You have to know what patients are losing. So that would be like my first step was like, okay, let's get a body comp done, whether and you can send people to gyms and they can easily get that done. But then that's your starting point, and you can kind of see, how much work you have to do. And when patients can see that, and they, maybe they're not going to know exactly how much muscle they lost, but you're going to know where they're at right now, and then you can talk them through the importance of that, and then whether they still have visceral and what is their state of metabolic dysfunction, because a lot of people think that, oh, I lost 30 pounds, I am good. No, I mean, they're probably in a worse metabolic state. So I think, really kind of bringing awareness to those important pieces that they haven't even really been thinking about is a really a good kind of a good starting point. Okay, some other questions here. It's not, it's the nausea and overcoming it. There has been the hardest for some nausea. Yeah, they're on the wrong dose. They're on the wrong dose. They're on too high of a dose. You got to go down on the dose if there's a lot of nausea. But again, if they have pre-existing gut issues, that's going to also contribute to the nauseousness. Constipation is the main challenge. I have not only worked with I've worked with a few. The NP I work with uses a very low start. So yeah, so nausea is there, but not severe. Constipation, we definitely see it. We don't see it a lot. It's usually not a huge issue for most people, but we're using the typical stuff, 400 milligrams of magnesium, a day. I, for the longest time, I've been using warm water with squeezed lemon. It's honestly, I feel like it like works every single time for people. And just little, I mean, we have just like a sheet, and we can actually share that with you. We have like our, what to do when you have constipation. We usually can resolve it if somebody says, I've always had normal bowel movements and now I have constipation. That's easy fix. But if someone's like, oh, I have constipation, but I've always had it my whole life, well, now it's probably there's something else going on. So that warrants maybe looking into some other things. For body comp, would you prefer DEXA every 3 to 4 months or InBody monthly? I believe the DEXA is similar to the InBody. We do InBody monthly. We don't do it. I would never recommend anything less than that. And DEXA, I'm not really sure about DEXA. Is it a little bit more sophisticated than InBody? I don't know. We do InBody monthly. And that seems to just, work really, really well. All right. Anything else? Okay, DEXA's more expensive, harder to find. Yeah. Yeah, we feel that the InBody, I'm sure it's not perfect by any means, but it's comprehensive, and as long as we can see the muscle mass, the lean body mass, and the visceral, that is super important. Okay. Oh, good. I'm glad this was helpful to you guys. Yeah, we're super excited. We have a lot that we want to talk about in the next, obviously this is, 7 more weeks. So we definitely want to hear from you. And I believe Erica is going to be sending out just a quick feedback kind of survey because we want to make sure that we address your needs. So I guess that's it. Like I said, if you have issues with Thinkific, everything's going to be there today.